Christine and I are going to go ahead and get started. For those trickling in, feel free to just start listening whenever. First off, Christine and I would like to introduce everyone that's currently listening to the first ever global journal club that's going to be hosted by the AOCPMR. We're hoping that this can become hopefully, either a monthly thing or a, weekly type of thing. Please use the chat option on the side. Christine and I are more than welcome to accept any type of feedback. Like I had mentioned in the email, it's going to be kind of a trial run, so there probably will be a lot of bumps in the road, but we really hope for those attending and listening that you guys are going to enjoy it. Feel free to chat with your fellow colleagues and classmates in the chat option, but I'm going to go ahead and we're going to go ahead and get started. I'm going to start by introducing myself. My name is Stephen Despins. I am the co-chair on the research committee as part of the student leadership on the AOCPMR. I'm a fourth year at Campbell University, and I'm happy to be joined by, I'm going to allow her to introduce herself. Go ahead, Christine.
All right, thank you, Stephen. My name is Christine Coe. I'm a fourth year at Western University, and I'm also one of the co-chairs, and I'm just really excited to see what we're going to do today, and hopefully this will be something that we continue from here.
All right, well, thanks for introducing yourself, Christine. I guess we're going to go and get started, so hopefully, for those that are using the computer, you should now officially have access to my computer screen. So anything I kind of type or show, if you're using the computer instead of the phone, you should actually see anything that I'm explaining. So what we're going to be doing is we're going to be discussing actually the monthly journal club that was released back in October. For those of you that don't know, as members of the AOCPMR, you guys actually get access to the monthly journal club, and the article is posted online. So as you can see, we're looking at the article we're going to be discussing tonight, which is the impact of needle diameter on long-term dry needling, treatment of chronic lumbar myofascial pain syndrome. But as you can see on my screen, or for those listening, gives a quick kind of rough introduction of the article, and then the discussion points that Christine and I are going to be discussing after we introduce the article, and we'll allow you guys some time to kind of answer the questions, post what you think, and then me and Christine will kind of summarize what you guys were saying. So we're going to go ahead and get started. So again, I'm going to load up the article. So we are discussing myofascial pain syndrome. So let me ask to start with you, Christine. What is your kind of definition of what myofascial pain is?
So I was looking this up, and it's interesting because the pathophysiology is actually not very well understood yet. They have a few working theories, such as there's a sensitization to a low threshold, or maybe a dysfunction at the end motor plate. But even before we get into that, just clinically, what you're going to see is a tightness in the muscle with the tender, maybe some popping or clicking, something that's stiff, and like a very local twitch. So it's really anything that we would see in any musculoskeletal case. So it's hard to really pinpoint what it is. But some things that they have used clinically are such as the jump sign. So as the name implies, when you press on that myofascial, they're called trigger points, and we'll define trigger points versus tender points later on. The patient will jump because of that exquisite pain. Also, as you run your hands perpendicular along the muscle fiber, so if you imagine like the hamstrings, for example, we're going to run it horizontally because that's perpendicular. You're going to find a ropey or a tight spot, and that contributes to that pain syndrome. And there's really no particular study that you can do to kind of diagnose the syndrome. You could look for other differentials like hypothyroidism, hypoglycemia, vitamin deficiencies, all things that would lead to kind of muscle atrophy or proximal muscle weakness. But there is one study that I found that showed that EMG actually shows a high voltage spike at that trigger point. So far that's how I've defined myofascial pain syndrome.
Okay.
If anyone has anything to add to that, feel free.
We'll give a second or two to see if anyone wants to post in the chat their own comments. We'll just give a second. Feel free, guys. Like I said, you can use the chat option. For those on their computer, I understand those that are listening over the phone, you can't really kind of weigh in specifically, but we'll give you guys a chance if anyone wants to post what they think, myofascial pain is, and then we'll go ahead and get started discussing the actual article.
So Kelsey just asked a high what spike. So when you do an EMG, you'll see a high voltage spike. So your EMG is a way to kind of look at the muscle functions. It's very difficult. I have no idea how people identify the sounds that they do. They kind of hear a sound and then look at a corresponding electrical voltage to diagnose certain other musculoskeletal diseases. But in this case, you'll see like a high, kind of like imagine like a electricity spike, just a very sharp, like a peak T wave on your EKG, kind of like that.
Alrighty, so we are discussing tonight the article published recently in the American Journal of Physical Medicine Rehabilitation and by Wong et al. 2016, entitled "The Impact of Needle Diameter on Long-Term Dry Needling Treatment of Chronic Lumbar Myofascial Pain Syndrome." So I actually was the one that actually submitted this article for this month to chat about. As Christine already kind of gave us a basic definition of what myofascial pain is, I think it's super important, for all of us choosing to pursue the field of physical medicine rehabilitation. We will be dealing with a lot of patients with chronic low back pain. Obviously, we have our OMT toolbox that we can help treat someone with low back pain, but obviously sometimes that might not be enough. So what I found significant about this article was not only to learn about another option, another alternative treatment option for myofascial pain, but also that they've shown that actually the needle size may actually play a role in helping treat someone's low back pain. So to get down to it, as you guys can see on the screen, we're looking at the abstract right now. So pretty much Wong et al., they went ahead and wanted to see whether the diameter of a needle that's used in dry needling would actually play a role in decreasing someone's myofascial pain, specifically low back pain. And so what they did was they ended up separating the patients into 3 different groups. Each group corresponded to a certain needle size. The 4 sizes they investigated were 0.25 millimeters, 0.5 millimeters, and 0.9 millimeters. And the way they were assessing pain was that they used 2 pain scales. The first one, I'm sure everyone's fairly familiar with, is the visual analog scale. So what is that? If you're looking on my screen right now, pretty much people draw it differently, but pretty much it's the classic question that you ask patients. On a scale of 0 to 10, how would you rate your pain? 0 being no pain, 10 being the worst pain in the world. The VAS, or the visual analog scale, is actually like this line, and patients just mark where they feel the worst pain is. So if you see my little mouse right now, if I'm having like 7 out of 10 pain, they probably would mark, roughly around here. Now the other survey that they had their patients fill out is what was known as the 36-item short form survey, also known as the SF-36. So I didn't actually know what that was, so I went ahead and did some research to see exactly what it was. And so if you guys are looking on my screen right now, this is kind of basically what the questionnaire is. Patients answer 36 questions that pretty much relate to how they're dealing with pain, and they rate it, and it's scored from 0 to 100. 0 being terrible, as in you're like severely disabled, to 100 where you're not disabled at all. And so they answer these 36 questions, and they had their patients do that. And needless to say, they found that the larger the diameter of the actual needle that was used for dry needling, patients reported that their pain scales were actually lower. And so that was actually very interesting. So no matter what the needle size was, patients reported a decrease in pain. So whether it was 0.25, 0.5, or 0.9, doing dry needling as a form of therapy did show improvement in patients' myofascial pain scores. However, they did notice that the larger the diameter actually had more of a role. So if you're looking on the screen right now, these were the three different needle sizes that were used. Obviously, the ones on the left were the 0.25 and the 0.5 and the 0.9 needle sizes. And here, as you can see right here, here's a photo of kind of how they performed the dry needling in the office. It's kind of, I don't know if anyone's actually familiar with dry needling. Christine and I will get to it later on in the discussion questions, but dry needling is different from acupuncture. So those that are, are kind of familiar with acupuncture, not familiar, they are two separate things. Dry needling is more can be performed by both physiatrists and physical therapists because there's no medication involved. However, when we discuss other options such as like trigger point injections and acupuncture, that's generally performed more by a physician because obviously you're actually dealing with medications, which physical therapists actually are not licensed to use. So I found that it was a pretty interesting article. Again, I thought it related really well to our field because it showed alternative to just medication to help treat low back pain. So I guess I'll hand it over to you, Christine. Did you have any comments about the article, or you find anything interesting about it?
I thought, I was interested to see why they chose the SF36 health survey. I know it's a very widely used survey to kind of measure like where someone is in their activity of daily living and their pain skills. But we'll discuss that later on. There's a question in our discussion about, if there's any other maybe pain skills that we can use. And it's hard because pain is such a subjective thing. So it's like, how do we quantify and how do we know if this really contributes to the validity of the study at all with such a subjective measure?
Absolutely. Let's go ahead and kind of open up the floor to those that are listening in. Feel free to shoot some comments at about whether you read the article or not. If you guys have any opinions, we'll go ahead and kind of summarize those. So we'll give you guys a minute to kind of post your thoughts about the article. If you didn't read it, it's okay. I mean, that's why we were discussing it. But for those that actually read it, if you guys have any comments that you guys would like to add, we'll leave it open for a minute just to see. So just bear with us. Be a little downtime right here. Okay. No one's really posting. I don't know if that's because people don't know how to use the comments section yet or not. We'll for future discussions and future journal clubs, we'll definitely hopefully explain the directions a little better. I know my email wasn't the greatest. It was kind of hard to explain it, through words, but hopefully, for future ones, we'll have a better system and hopefully help you guys out. Mike's got a question. How did they organize their control group? That's actually an interesting question, Mike, because they really didn't actually have a specific control group, and they actually said that they actually mentioned that down here in one of the limitations of the study, because each of the three groups was a treatment group. So they admit that it's kind of hard. There could be outlying factors that actually might be playing a role, but as you can, but yes, there wasn't specifically a control group. So yes, outside factors were still kind of hard to control. However, one of the inclusion criteria that they had for their patients specifically was that if the patient had received any other type of treatment, acupuncture, physical therapy, trigger point injections, within, I believe, 6 months, those patients weren't qualified for this study. So they tried to keep it pretty limited on, how early on did they get actually intervention for their back pain if they had received other treatment modalities in the past. But yes, there wasn't specifically a control group, so that definitely was a limitation.
So what would you think is a good control group? Would it just be no treatment, or what is I guess what other modality would serve as a good control group for this?
That's a good question, Christine. I actually don't know the specific answer because, I mean, the whole point of dry needling, and we'll get to that in the discussion question, is it's the actual benefit of the treatment isn't so much. Remember, dry needling doesn't have medication, so you're not really. There's no medicine going into the actual muscles to help the muscle heal. It's actually the needle motion, from my understanding, is what actually is the actual benefit of dry needling. It's actually the needle going into the muscle, and actually the movement of the needle, breaking up the adhesion, freeing up the nerve block. Is, from my understanding, that's what actually is actually where the patient actually gets benefit.
And Michael brought up a good one, maybe not needling in the trigger point. And I would respond to that as in, I guess, where else would we possibly dry needle, and would that be harmful in any way to dry needle in a non-trigger point? So that's something we can maybe look up and talk about too next time.
Absolutely.
And then James asked, what kind of treatments would you try before doing dry needling? So I pulled up kind of Medscape's take on myofascial pain syndrome.
All right, let me swap you, Christine, so they all have access to that. Let me switch to your screen so that you have access to that. All right, you should be able to do that now, I believe.
All right, so on my screen right now.
Yep, there we go.
So this is just kind of treatment and management. So I was just looking, there's a whole ton of other PT type things like massage, exercise, stretching. I would even include, your common NSAIDs, anything to relieve pain. And if that's not working, then I would say at that point you would move on to something a little bit more invasive like dry needling. I don't know if it's necessarily like a first line treatment for myofascial pain. And then, we're all DOs here, so could always do myofascial release, although some argue that it's too superficial. It wouldn't affect the deeper tissues. So it would just depend on your take on, I guess, myofascial release as well for that.
And obviously, how well, if you've built a rapport, just because we're going into a great field where, building a rapport with your patient's super important in physiatry. So if you've been seeing this patient for a while and, you're not getting any improvement with one modality, that might be actually the option now is to try dry needling or one of those other forms of therapy. But I don't know if there's specifically a first line treatment. I guess I would argue probably it would just be stretches for the back, stretches and like Christine had mentioned, stretching, myofascial release, and massage. I guess one would argue, and then you could go higher up. But everyone everyone's body's different, so one modality for me might not work the same for you, Christine, and vice versa.
So that actually brings us very nicely into our third question. Unless anyone has anything else to add to any other forms of alternative medicine that we can use, I'll give you guys a second here. These are just some example of physical therapy in OT, but acupuncture I would add to that list. But if anyone else has any opinions about other forms of medicine that we could use, go ahead, and we'd love to hear it.
Okay, so we're going to go ahead. If no one has any other questions, we're going to go ahead and get started with the discussion questions. Christine. I'm just going to kind of swap back to me so they have access to the actual screen. Again, so they can see.
We hit 1 and 2, so we can actually go on to 3. It's a good flow today.
Oh, okay. Give me 2 seconds. All right. So, no, I don't want do that. Yeah, so the first discussion point was actually describing what myofascial pain syndrome was and how it's diagnosed. Now, Christine gave an excellent definition at the beginning of our podcast / program, but for those that might have joined in late, you want to, Christine, throw in like a 1 minute, maybe 30-second quick definition again for our listeners that might have joined in late, and then we can move on from there.
Yeah, sure. It's actually, I don't know if you guys can still see my screen, but it's right up here, but I put it together. It's essentially like a very, it's a bundled tissue. It's tight, it's tender. When you press on it, someone's going to jump. It's associated with just kind of, just unretractable pain. And a lot of these patients will have these Ropian type spots that are perpendicular to the muscle fibers. So that's what we're talking about in this myofascial pain syndrome.
Okay. Alrighty. So Christine did an excellent job describing the definition. So we're going to move on to number 2. So again, the second discussion question was asking what is dry needling therapy, and then a follow-up question is, can you think of any other forms of alternative medicine that have been used to treat myofascial pain? So again, we've already had a big discussion from Michael or Tyler, I can't remember, had asked, are there any other forms of medicine besides dry needling? But I'll go ahead and get started with describing exactly what dry needling is. So dry needling is literally what it sounds like. You're taking a needle, and I showed some pictures earlier from those that were listening, and you're placing the needle into where the patient's greatest pain is, the quote-unquote trigger point. Don't get that mixed up with a tender point. Christine will, in the next minute or in the next few minutes, describe actually the difference between the two, but you're identifying where the trigger point is, and you're taking the needle and going into the muscle. And from my understanding and from what I've learned from my attendings and from physiatrists that I've worked with, it's more the actual needle going into the muscle that's actually what's doing the benefit for the patient. Now, how is that different than from, say, what a trigger point injection is? For those that aren't familiar with a trigger point injection, that's actually when you use a medication. Generally, most physicians like to do a little bit of lidocaine with a little bit of steroid, and they inject it into those tender points, and usually they'll do like 6 or 7. And the difference, again, from my understanding from the physicians I've worked with, it's not actually so much the medicine when you do even a trigger point that's actually what's actually improving the patient's pain. It's actually the motion of the needle going in and out. For those that are wondering, well, what's the difference between dry needling and acupuncture? There's actually a big difference. So acupuncture has been around since, don't quote me on my history, but it's been around for centuries. It was first developed in our Eastern society with the Chinese, and they've perfected it. You can actually go and take a course once you get your license. If you're interested, you can actually go take a course, and it's a pretty intensive course and get certified. And pretty much the Chinese were able to outline the entire body, and there are these perpendicular lines that are drawn throughout the body that relate to the different organs, such as the liver, the spleen, and they're all connected where if a person's having some sort of issue, when you put the needles in that certain line, the patient generally will start to feel better. And for those of you that aren't maybe sold on acupuncture or not familiar, I've actually had acupuncture done to me. I specifically actually had it done. I had what's called ear acupuncture, so it's a whole different discussion down the line, but if you're interested, Google ear acupuncture. But the ear itself, there's a point on the ear for every point in the body. And so I was working with a neurologist this past year, and I actually ended up breaking my 5th toe, and he did some ear acupuncture on me for the fifth toe spot, and for the fifth toe, and he injected the needle into my ear, and I kid you not, my toe literally went numb, and I kept the stud in there for a couple days, and anytime I wiggled it, my entire toe would go completely numb. So I'm a firm believer in acupuncture. Whether you'll decide from your own clinical experience if you agree with it or not, but it's interesting field of medicine where I highly encourage anyone that's looking to go into, pain medicine or just, physiatry in general. It's definitely something that you guys should start doing some research, just learning about it, because you will have a lot of patients coming in that will not want to do the typical treatment of just doing, pain medicine. A lot more Americans are starting to try going away from pain medicine and trying to find those alternative forms. So it's a great treatment option, dry needling, physical therapy, acupuncture, instead of, strictly just giving, the tramadol or the oxycodone or the Percocet to help with someone's pain. Do you have anything to follow up with that, Christine?
No, I think you explained it well.
Okay. So we're gonna go ahead and Christine's gonna go ahead and start the third discussion question.
Yeah, so just quickly, what's the difference between a tender point and trigger point? And like someone brought up, I think Tyler, that it's very hard to differentiate that, and Kelsey also brought up a point that tender points may be palpable. So I just want to go over it to clarify. So trigger points are what we're talking about when we're talking about myofascial pain syndrome. Like we said, these are palpable nodules, and it's interesting because right on that point, there's that jump sign, right? So patients are feeling allodynia and hyperagesic at that point. Whereas when you go to a tender point, Kelsey, I'm not sure if when you say palpable, it means you can find a specific point that would elicit pain, or is it palpable as in you feel a nodule? So I think in this case, a tender point, they're arguing, and this is from a research article by Shreve 2011, that the tender point is actually a point that elicits pain, but it's not palpable. And Tyler brought up the point that what most people identify in OMT are trigger points. These are your muscle knots versus a point that is hypersensitive. So other things that you can kind of look for is a trigger point. There's kind of a pattern of referral. So the pain center might actually be somewhere else, like a muscle somewhere else that kind of refers to that spot. Whereas in a a tender point, see, I'm already mixing this up. It's close to a muscle attachment. It's where there is that tendinous junction and creating kind of a different tissue texture as well. These trigger points are more like local contractors, like we've been talking about. So when you biopsy them, that's what you see. Versus the tender point, you don't really see much histological change. And just an interesting point, I'm not sure how it's figured out, but trigger points, they argue, are more peripherally mediated, whereas tender points are more centrally mediated. I see a lot of activity going on in chat. So
yeah, there's a lot of people arguing back and forth. I'll give my quick, as people are chatting in the comment section, I'll let you take a chance, Christine, to read what people are saying. But from my understanding, and I'm just referring to the classic good old Dr. Severese, green book that we all so love when it came to board studying, and for those that are still board studying, for COMLEX and whatnot. From my understanding, a trigger point has referred pain, and the pain travels, so it radiates somewhere. So as Tyler and Michael were saying, for example, a classic trigger point for headache in the cervical paraspinal muscles will actually radiate up into the ear area and around the ear. Now, that's different than a tender point. Tender point is what we learned in the OMT lab. That is a specific spot that does not radiate anywhere, and that's where you can use counterstrain for. Everyone's familiar with counterstrain technique. Counterstrain is used to treat tender points. Counterstrain is not used to treat trigger points. Trigger points are treated with all these different modalities that we've been discussing: the dry needling, the trigger point injections, massage, myofascial release OMT, and medications. But from my understanding, I always thought that was the two differences. But yes, a lot of physicians tend to use the two terms interchangeably, but if you like to be a stud and try and have a conversation with your actual, attending, you can be like, no, Dr. So-and-so, I actually don't believe that's a trigger point. I believe that's a tender point because, it's not radiating or whatnot. It's a good opportunity to, have a discussion with your physician, your attending physician.
Yeah, so I'm just going to kind of refer to our school OMN manual. We have our own if anyone's interested in purchasing the Western U OMN manual for selected conferences. Anyways.
We would like to say before Christine goes, we take no financial interest from anybody. We're just quoting that now.
Oh, yeah, of course. But so counter strain, like I think people are saying, is mostly an identification of a tender point. I think you mentioned that to Stephen, and it's interesting because it's very confusing with trigger points and Chapmans. At our school, we like to define Chapmans as, for those of you who drink bubble tea, like a boba, like a little crepitous nodule. I don't know if anyone else in their schools describe Chapman as that, but that's how it's described to us. It's yes, boba. So just now that we've kind of identified what the difference is, hopefully we can try to keep those in line going forward. And, if there are further kind of arguments or further discussion, we can definitely as well look stuff up and come back next time and talk about it again.
And I agree with that, Michael. Many medical professionals use these terminologies, not just in osteopathic medicine. I completely agree. But just be aware that sometimes the two terms are used interchangeably, and they actually, are two different things. So don't let that get confused with you. As you're diagnosing a patient and your physician comes in and is like, oh, that's a trigger point, and you're like, well, I'm not so sure, Dr. So-and-so. I think this might be actually a tender point. You can say, well, how are you going to treat it then? You can be like, well, I'm going to use counter strain, or no, I'm going to give the patient a trigger point injection. So just something very important to think about as you guys go throughout your clinical career, on your clinical rotations while you're in the lab. So it's just a great opportunity. Does anyone else have anything they want to add before we move on to kind of the next discussion question? All right, we'll go ahead and move on. So question 4, me and Christine wanted to kind of throw out there was wondering whether obviously from the article we discussed, the diameter of the needle does play a role in dry needling, but what we wanted to know was, do you think the diameter of the needle could play a role in the other treatment modalities that generally use a needle, such as trigger point injections, nerve blocks, acupuncture? I personally believe from this article, I would argue I think it would play a role. Now, I'm not an expert. Whenever my attending physician tells me to give a trigger point injection, I'm just handed the needle, so I never really thought about, will the needle size make a difference of whatnot. But I would argue, Christine, I think it would. Would you agree with that?
Yeah, I think you're creating more mechanical disturbances. Well, actually, I take that back, because you could theoretically, with a smaller needle, cover more surface area as well. But I see the point with the larger diameter giving you kind of more to work with, if that makes sense.
I would be most interested to see if it actually played a role with acupuncture, because as I mentioned before on my long acupuncture rant, that form of medicine has been perfected over the centuries, and I would just be curious to see if they had already done this research in the past, just from seeing all these different patients, that they've actually perfected the specific size needle that you use for acupuncture, or if there hasn't been a study yet done. I'd actually be curious to see that, but I think it'd be really interesting. Does anyone in the chat have anything they would like to add? I see Tyler Bates said he kind of agrees with what we were saying. I think someone else had posted too that they were interested, and they agree. But I think it's a pretty straightforward type of answer that really the only way to know is if we would do some sort of study to really kind of answer the question. So going back to the discussion questions, question number 5 kind of asked, and we had kind of already alluded to this when we were discussing the actual journal article, was do you think the VAS score is an accurate way to measure pain? For those that might be joining in late, I'll show again kind of what the VAS score is. It's the general question that you ask patients from a scale of 0 to 10 how bad your pain is, and you'll give the patient this little chart right here that I'm showing, and they'll mark how they rate their pain. So if it's like a 10, they'd mark on the far side. If it's like a 1, they'd be more on the left. But I'll switch it over to you, Christine, and see. Do you think there is a better way to measure pain? I mean, we're just taught in medical school. When you ask a patient, your classic HPI questions, you always just say, "How would you rate your pain scale on a scale of 0 to 10?" Do you think there is a different way that we could theoretically do it, or do you think this is really kind of the only option?
So I was doing some reading about the VAS, and it's been around for a very long time. And I think Michael just brought up a point that, as much as we all hate it, it has its validity, reproducibility. As in, people have shown time and time that, surprisingly, it's one of the most accurate way that we can kind of define pain. Now, pain is just so subjective that I had a discussion with a patient the other day. What does a 10 out of 10 even mean? Because for me, a 10 out of 10 is, the worst pain, but someone else's 10 out of 10 might mean, a little twitch in the muscle. It just depends on the pain tolerance and your self-perception of pain. So that said, I personally feel that there has to be a better way. Michael said it's useful to establish baseline and see if there's improvement. I agree, since it is used on an individual basis. If a person comes in on day 1 with 3 out of 10, we can only assume that on day 2 a 7 out of 10 would mean an increase in pain for that patient. But it's definitely not a useful tool to compare patient between patient. I found this article, and the link is down here, which I will send out. I'll send this out to everyone once we're done. But I think it is. Sorry, I have many tabs pulled up here. So this is actually really interesting because it has all these kind of different pain scales that we use, and it shows you kind of the research that has been done on it and what it is. So when you guys have time, I think this might be a good article just kind of to read if you're interested in pain medicine, to find out what really is the best way. I'll be honest, I haven't been through every single thing.
I'm looking at it right now. I'm getting a headache. It looks long.
It's a lot. I'm going to say when you have time, I think you can kind of go through it and just kind of see what people feel. Disclaimer, this was used in a rheumatologic setting, so there could be also some discrepancy there. But anyone else have any other pain scales that they like? I can tell you that I do not like the Likert scale, which is the one that says like somewhat disagree, agree, disagree. I think that's a very tough one to answer. How do I know if I'm agreeing versus somewhat agreeing? Michael says that I can't pronounce that, I'm so sorry. And he has a great link there. Oswestry
Disability Index. Apparently it's from Michigan State. For low back pain.
Thank you, Kelsey, for joining in.
Yeah. Thank you, Kelsey. Yeah, so moving on to kind of the next question, and we had already again alluded to some of this when we were discussing the article, and it's just a general question about asking how this study could be used to further improve, treatment for myofascial pain. So we've Christine and I have kind of already chatted about this, but I'll kind of reiterate it again. Obviously, the article did show that the diameter of the needle does play a role. So, the next time maybe you're seeing a patient and your physician tells you, oh, go ahead and do a trigger point injection, you could be more the stud and be like asking the physician, oh, what gauge needle are we going to be using? And they can say, we're just using the typical one that we always use. I'm not, off the top of my head, I can't remember the typical so-called size that they generally use. Like I said, they usually just hand me the needle and say, go ahead and inject. But you could always be the stud and ask, what size are we using? Because for this recent article that was published, it seems like the diameter actually plays a role. And this is important too, because when it comes to referral, when you're referring your patients to PT physical therapy, I had mentioned prior that physical therapists perform dry needling. They don't perform trigger point injections because they're not allowed to, prescribe medications, because trigger points actually involve, giving some steroid and some lidocaine. So this is important too when you're referring your patients to physical therapists and you think that they're going to be doing dry needling to help their specific patients. You can always inform, the PT that are on staff that, I'd prefer the patient to use this size needle because this recent article suggests that it actually has a better role in treating the patient's myofascial, low back pain. And, you can have a discussion with the PT team there. That's how I would approach it. And I've kind of done that now. I'm not currently on a PM&R rotation as we speak, nor am I doing trigger points. But the next time you have to give a trigger point, I'm definitely going to be a little more proactive, asking my attending physician, what size gauge needle are we using? Do you have anything to add, Christine, on that side?
Not particularly to the question, but Tyler brought up a good point about for those of you who have seen or been taught trigger points, how many have seen them just inject one spot versus moving around, breaking up the trigger point? So personally, I've worked with someone who does this, and he will inject and dry needle at the same time. So that means he would inject the lidocaine and the steroid, and then he'll use that same gauge needle, usually like a 22 gauge, and he will kind of go in and out, kind of like dry needling, but at different angles. Has anyone else seen that?
Yeah, I agree, Christine. The physiatrists I've worked with, or even those that family medicine docs and other physicians that just do trigger points, I would agree they do a similar technique. I don't think, Tyler, I've ever seen just one specific just trigger point for just one spot. Most of the doctors I work with generally do symmetrical points. So even if the patient's having, say, left neck pain, I've seen the physicians I work with, they'll usually do, 4 on the left side, 4 on the right, just to be symmetrical. They wouldn't just do it on the one side. Every physician's different. People would, just from their experiences working with their own patients, ones would argue, I do it this way because I get the best results. I noticed that generally, especially the PM&R doc I worked with recently, what he does is he actually does the trigger points, and then he actually does some OMT. So he'll actually immediately do some muscle energy to help stretch the muscles to get even that added benefit of effect. I don't know, Christine, if you've seen any of the physicians you work with that actually incorporate OMT right after doing the trigger point.
Yeah, definitely. That same doctor that I worked with was a big proponent of, you would come into the clinic, you would get your ultrasound stim, massage therapy, and then OMT, and then your injection. His argument is he wanted to prep the muscle for the medication and for the dry needling. So I think there is definitely a component of OMT that can be used. Okay. James asked, what are some contraindications? And I don't personally know. I'm looking them up. Some absolute ones that I found are patient with needle phobia.
Never, yeah. Don't do trigger points or dry needling if your patient doesn't like needles. That's probably not a good idea.
Other absolute contraindications include people on anticoagulants, thrombocytopenia, which would make sense if, they're prone to bleeding. We don't want to aggravate that. Also, to an area with a lot of lymphedema, and the argument for that is that it could be a nidus for infection, so you don't want to aggravate that point, much like any other injections. And then some other relative ones are immunocompromised patients, patients with slow healing time, like diabetic patients, pregnancy for the hypercoagulable states. Those are the few that I've found so far. Anyone else have any other? Yeah, local infections, cellulitis, abscess, that's great too.
Yeah. Obviously, always use your own clinical judgment as well. Just like, OMT, we have those, those lists of, contraindications. Everyone always says cancer, but some people even argue for OMT with cancer can be both beneficial and actually contraindicated, because it could be helpful to actually get the medications, especially like a lymphatic treatment actually could be beneficial for cancer treatments, cancer patients, because you're actually spreading the chemotherapy out and getting it to where it needs to go easier. But then also people argue, no, you can also spread the cancer that way. So there's always pros and cons. So, you have to, as a physician, kind of use your own clinical judgment as well. Michael's showing that made a comment saying there's no study that proves either. So I kind of agree with that as well. So moving on to the last discussion question is, and we, again, a lot of these questions already overlap, is with this new information, how would you incorporate this information into your own medical practice? I don't want to sound like a broken record, so I'm not going to kind of repeat what I had said from number 6, but now I'll be a little more proactive. I know for me, as I had mentioned already, that if I have to go do a trigger point injection, or happen to be handed a needle and say try some dry needling, that I'm probably going to be asking my physician now more like, what size gauge needle are we actually going to use, because I read this recent article that shows that the size actually can help make a difference in the patient's actual pain. So like I said, this discussion question is fairly similar to the one we already mentioned before, but I highly encourage any of you, that are interested in, looking to pursue any form of, pain medicine, or, you're into musculoskeletal medicine, or spine MSK, that you will be exposed to low back pain on a regular basis. Even if you're not going into PM&R / pain medicine, if you go into family medicine, low back pain is the most, I believe from it's the number one cause of coming into a physician's office. So you don't even have to be a physiatrist. You will be seeing these types of patients in whatever field you go into, GI, cardiac, renal, heme, onc. You will have patients with low back pain no matter what. So it's important that you have a firm understanding of what type of options are available out there, because as mentioned earlier, there are still plenty of Americans that want just the pill, and everyone wants to just take a pill and hope the pain goes away. But a lot are starting to understand the negative consequences of these long-term pain medicines like Percocet, oxycodone, morphine, tramadol, etc., that a lot are trying to move more towards the alternative forms of medicine, such as OMT, trigger points, exercise, physical therapy, occupational therapy. And that, as physiatrists, is really important for us, because that's our role in medicine. Our goal is to maximize function for the patient. So we need to do what's ever in the best interest of our patients, so helping them to get back on their feet. And if they're wanting to try these other forms of alternative medicine, we need to be able to be open and willing to work with our patients as well. I don't know if you have anything to add on that, Christine.
No, you summed it up pretty well. I think pain is definitely very prevalent, and any ways we can, utilize to help our patients are worth learning, really.
Yeah.
I think James brought up a question about how do you know how far to push the needle in. That's a great question. Anyone have thoughts on this? Because I have never asked an attending that question, nor have I ever done this. So maybe Even, do you have any idea?
Yeah, I'm gonna relay what Tyler already had written in the comment section. It kind of depends on the location, obviously, depending on where you're doing the dry needling or the trigger point injections. Obviously, if you're closer to the neck and you're doing trigger points near the cervical paraspinal, the apex of the lung is pretty much right there. So you have to be very careful when you're inserting the needle, because obviously if you go too deep, you can cause atelectasis and puncture the lung. Same with any other points on the body. Obviously certain organs are deeper than others. When you're doing generally the low back, the paraspinal muscles of the low back, you can go fairly deep because there's so much meat in those areas. Now, like I said, as you get closer to more of the cervical area, the cervical region, it's generally you don't go as deep because you're at risk of puncturing the lung. But also you have to take into account people's body habitus. So if you're dealing with patients that's super thin, you don't have to go nearly as deep because you'd be hitting bone like immediately. Because if you do it on someone like me, I'm mostly skin and bones. You don't have to go that deep. But if you're going with someone that might be obese, morbidly obese, there's a lot of fat that you have to travel through, and sometimes that's the issue that patients that are more overweight will argue they don't get a benefit from trigger points or dry needling. And part of it's not so much that the physician's doing the wrong thing technique-wise. It might just be they're not able to reach the point because of the patient's body size. So that all plays a role. So that's why as physiatrists, we want to make sure we're encouraging our patients, mind, body, and spirit. I know it's very hard to convince a patient to go exercise, but the fact of the matter is exercise is still the number one cure for any of these conditions. It's the best form of treatment. So if you can really encourage your patients to get up, try and lose some weight, exercise, meditation, yoga, tai chi, all those other forms, it all goes a long way, and people are slowly starting to realize it, but sometimes they need someone, and that's where us as physicians comes in. They just need someone to tell them, no, if you go exercise or if you do this, you will start to feel better. And I can tell you from my personal experience, it seems kind of intuitive, like exercise, but I mean, if you tell a patient to go exercise, they're more likely to do it versus not telling them. So always highly encourage your patients, to do that and to eat healthy, decrease smoking, all the things we learned in medical school that you learn from day one you shouldn't do. I mean, the studies have shown the most basic concepts are actually like the most beneficial for our patients. So, but to go back to the depth question with the needle, absolutely, I would say it depends more on the main two factors are patient size and actually location of the actual trigger point. So closer to the more cervical area, got to be a little more superficial. You're down in the lumbar area, go to town with it. You can go pretty deep because you got a lot of muscle there. So I don't know if you have anything else to add on that, Christine.
No, like someone said, preach, brother.
I went on my long preventive medicine rant right there. Sorry about that, guys.
But yeah, I think that was good. I think right now we just want to open the platform up for any sort of feedback, any ideas. I'm wondering how you guys feel about the chat function versus being completely involved. If we had unmuted your microphones, for example, anyone have thoughts on that for next time? Or any feedback at all, actually, on how this was run? We would love to hear from you.
Yeah, feel free to put it in the chat. If you guys have other ideas, that you just can't think of right now, feel free to either shoot Christine or I an email. I forget, Christine, do we have a general email for the AOCPMR that they can relay it through, or is it better for them to just kind of get our contact as the two research committee chair members.
You can email us directly. I'm about to type my email here.
Okay.
Steven, go ahead and.
Oh yeah.
So they have it.
Okay. Yeah, Mike, we'll do that. We will definitely send a PDF file next time with the next article. Two things I will say, though. If you guys check your emails, the AOCPMR does actually send an email out once a month with the journal actually attached. But if you're looking actually on your computers right now, I went ahead and took control again from Christine. On the AOCPMR website, if you go to the student tab, you can actually scroll down to, let me get my little box out of the way, I'm sorry. Oh, wait. And you can see the Journal Club tab right here. If you click on that, you'll actually get taken to the page that I just had up. And what it does is it has a list of all the journal clubs that are both future journal clubs and ones in the past that we discuss. And so, if you can't attend, the one that Christine and I host online every few weeks, you can host your own at your own school. We completely encourage that. That's a benefit of being an AOC PM&R member, is that you guys get access to all the journals, both past and present and future. And so our hope is that we plan on at least discussing the monthly journal club now once every few weeks with the new journal club. However, if you guys think, or if you guys really enjoyed this program, would like to do it more often, maybe more on like a 2-week basis or 3-week basis versus just the once a month, we're definitely open to that. Obviously, everyone's schedule can be busy sometimes, and that's why I'm actually recording this. I call it a podcast, because I'm going to be posting this online so that your fellow colleagues that might not have been able to attend can still download the podcast and listen. Christine and I's hope, actually, we weren't able to do it this time, but for future calls, we would love to have anyone that's currently doing research or has performed research in the past and maybe got a paper published and had any interest in discussing their research. We would more than be willing to have you guys get online. We'll actually allow you to speak on a global level to actually talk about your research projects, and then of course we would give some time for a Q&A for that. That's kind of in the plan for the future, and I had made a post in the email saying if you were interested to write that on the Google sign up. But if you're still interested, or if you're actually having a change of heart now where you're like, you know what, I actually want to do it, just let us know. We'll probably try and allow 1 or 2 students or physicians every time a chance to present their research. Obviously, we wouldn't have enough time for everybody every single time, but we would definitely give you a chance if you're interested, because the more we can learn about medicine, the better. I mean, we're in a field today now where everything is evidence based. So I'm constantly getting grilled by my attendings about what's the new best thing on Up to Date and whatnot, and I'm pretty bad at keeping up to date with that. I don't know if you're having that same issue, Christine, but we highly encourage you guys your guys' feedback, and that's all I have. I don't know if Christine, you have anything else you'd like to say before we sign off?
No, I think that's great. Just like we said, email us or anything. We just love to hear from you.
All right. Yeah, well, thank you guys for joining. We hope you had a good time. Please send us feedback, and we look forward to the next. We look forward to hosting the next one, which will be on the. I have it actually showing on the computer right now. We'll be discussing the journal article "Older Age as Prognostic Factor of Attenuated Pain Recovery After Shoulder Arthroscopy." So, for all those that are interested in orthopedics, it should be a good talk in a few weeks. We'll keep you guys updated on when we're going to host it.
All right, have a good night.
Have a good night, everybody.